Hello, my name is Alena Seresova, and I'm a medical speech-language pathologist at the Montreal General Hospital. And today I'll be talking to you about tracheostomy and communication. We are going to cover communication in tracheostomized patients, typical speech production and effects of tracheostomy on speech, basics of optimizing inpatient communication, non-speech communication options, and options for restoring speech. If we look at typical speech production, air from lungs travels through the vocal cords, and with the help of our articulators, which is the tongue, lips, teeth, gums, we shape the airflow to produce sounds. If there are obstructions at the level of the vocal cords, speech is going to be altered. And if there is obstruction at the higher levels in the upper aerodynamic tract, no voice, no airflow will be produced, thus no voice will be audible. It is possible to articulate without a larynx, and it is possible to phonate without articulators. The advantage of tracheostomy over endotracheal intubation is that we are able to articulate more because our lips and tongue are more free to move, despite the fact that there will not be any audible production. What is the impact of tracheostomy on phonation? The tracheostomy tube is inserted below the vocal cords. So any air that's going to pass through the tube is not traveling up to the vocal cords and or to the mouth and articulators. It is exiting below the cords. So it goes in and out of the trach tube, and thus there is no voice production. There's a small exception, esophageal speech, where we actually use the esophagus to produce a voice, but we are not going to be covering that today. What is communication in a hospital like? There is a big psychological impact of being unable to communicate when critically ill. A study from Grossbach talks about increased anxiety, frustration, and even fear of the inability to speak. It is very important to be able to communicate pain, discomfort, and symptoms so that we can optimize the treatment of our patients. And the patient should have the ability to participate in decision-making, which may be difficult if the patient cannot communicate appropriately. When I speak about communication, it is not necessarily just the ability to use your voice and speak, because as we will see later, there are many different ways and methods of communicating. How can we optimize communication with the tracheostomized patients? Number one, we minimize communication barriers. If the patient uses glasses, put them on. If they have hearing aids, put them on. If the room is noisy, minimize noise. Turn on the lights and ensure that the patient can actually establish eye contact with you. Assume the burden of communication. Communicate in the patient's strongest language. I can't tell you how many times I walk into a room, I see a patient, and nobody knows what language they communicate in. So let's find out what the patient's main language of communication is. If they are unable, because they have a tracheostomy, if they are unable to communicate in full sentences, asking yes/no questions instead of open-ended questions is much more efficient. And verify that you understand, again, by asking yes/no questions. What I mean by that is it this that you are talking about? And then the patient can again head nod yes or no, rather than assuming that we understood and presuming that that was the message that the patient was communicating. What are the non-speech communication options? Mouthing. We all think that speech-language pathologists read lips. No, we don't. Not that easy to do. But patients can mouth single words at times and can use their lips to communicate some simple messages. Writing, typing, texting, we'll return to that. Communication boards, and then more technologically advanced applications such as text-to-speech apps. So mouthing. If a patient is trying to mouth, and believe me, they will try, we should encourage them to speak slowly. Just because the patient is moving their lips and trying to get their message across does not mean that they realize that you are not understanding them. So let's encourage them to speak slowly and to really exaggerate their pronunciation and remove any barriers that there might be, such as, for example, facial hair. Focus on keywords. Is the patient trying to say a full sentence and you are lost in the words that are meaningless, rather than telling the patient, okay, are you talking about pain? So just say pain. Establish the topic. What are you talking about? Are you talking about your family? Are you talking to me about your loved one? Are you talking to me about your work? Supplement with the first letter. You can say, I can't make out that word. Point to the first letter on the alphabet board, which we'll see later, or you offer the alphabet, they can look at the chart that's in front of them. And if patients have dentures, it's always easier to produce speech with teeth or dentures. Writing. One of the easiest ways, if the patient has the dexterity, give them a paper, pencil, have them write. Easiest, most effective solution. It will be my dream that all patients with tracheostomy have easy access to writing material in their rooms. If those materials are not just in the room, but they are actually reachable, easily reachable by the patient so that they can use them whenever they need them. It is difficult to write on just a sheet of paper, so any clipboards, dry erase boards, markers, whatever we can provide is again much easier to use. And or patients can use, if they have the dexterity, they can use their cell phones or tablets and just type that way. Once again, ensuring that the patient has glasses so that they are able to see. Another option are communication boards. There are many visually based materials, whether they're alphabet, picture boards, pain scales, etc., that can be used. If the patient is able to point, if the patient has the cognitive ability to do so, and if it makes sense. There are many gestures and expressions that the patient can use without having to point to that. You know, if we smile, I don't have to point to a smiley picture if I'm able to smile. If I'm able to visually express pain, again, it is useless to point to a picture to express that. But there might be patients who are not able to do that, and at that point, it becomes useful. Last option would be text-to-speech devices. Previously, these were available only on very specialized devices. Now, any phone has many possibilities of text-to-speech applications. However, these are usable only if reading, cognition, and dexterity are adequate. One of the examples is Speech Assistant. Looks like this. It's a free application, easily downloadable and customizable for any patient that you may have. You can figure that out as you need. One of the barriers that your patients can have could be aphasia. Aphasia is an acquired language deficit, and it can affect all spheres of communication. It can affect verbal expression, auditory comprehension, reading, and or writing. It occurs in about 30% of people post-stroke, but it can be also present secondary to brain tumors or other neurological disorders. That being said, if you suspect that patients have a language deficit, such as aphasia, they may not be able to use one of your assisted communication devices and or communicate effectively because their language is impaired as well. Other speech options for alert, awake, and ventilated patients with preserved articulation and oral motor function could be talking tracheostomy tubes and or an artificial electrolarynx. Talking tracheostomy tubes are rarely used and will actually not be covered in this course. There is a special course for that, and I will not say more about it. If we look at artificial larynx, there are different models, transoral or transcervical models, and practically it's an external kind of a buzzing sound that replaces the sound of voice. The sound is shaped by the articulators to produce speech. Looks like this. So the one on the left is the external neck model. The one on the right is the intraoral model. And we have been successful using it with some of our long-term tracheostomized patients who had preserved articulatory ability and learned to use it to generate noise and attention and learned to use it quite well and liked it. So that is an option for some of our long-term tracheostomized patients. So how do we speak with a tracheostomy tube? Options for the cuffless and or cuff deflated tracheostomy tubes for patients off a ventilator. Option number one, the most natural one, is leaked speech. The air will flow around the trach tube through the upper airway, make the vocal cords vibrate, will be shaped by our articulators, and will be audible. It will not be a very strong voice, but it will be audible and good enough for 1 to 2 word utterances and production of some speech. This is usually possible with tracheostomy tubes that are smaller and cuffless. We can also do a digital occlusion of the tracheostomy tube, where we ask the patient to breathe in with our finger and glove. We occlude the tube, and on exhalation, the patient exhales and produces audible voice as they force the air around the tube into the upper airway. Another option are speaking valves, which I will address a little bit later. But all of these require some airflow around the tracheostomy tube. There has to be enough room around the tube, and we have to consider that some of these tubes have the cuff deflated, which creates extra bulkiness around the tube, but there still has to be enough room in the trachea for air to flow around to the upper airway. So if we speak about speaking valves, which speaking valves are used at the NUHC? You will see the question marks next to the Passimure valves. You may still see them. However, we can no longer order them in Canada-wide, for various reasons. So the ones that you will be seeing mostly are the white Shiley speaking valves that you can see here at the bottom. I included all 3 of them because these we still have some supply, and they are very specific and particular. So for now, you might see all 3 of them, but the one valve that you will see the most is the Shiley white speaking valve. So how does the speaking valve work? Speaking valve is a one-way valve that on inhalation, air goes through the tracheostomy tubes, and on exhalation, the valve closes, the membrane in the valve closes, and the air is forced around the tube up to the vocal cords to make them vibrate, and through the mouth exhaled out. If you look at my little schematic here, you take a breath in through the tube over here. Then here the valve by itself closes the membrane, and then as you exhale, the air can no longer go through here because of pressures, and is forced around the tube through the vocal cords over here all the way to the articulators, through the nose and through the mouth, to be exhaled and shaped into some intelligible or semi-intelligible speech. Who would be a good candidate for the use of a speaking valve? A patient that's awake, alert, and attempting to communicate. They have to have adequate oral function for speech and a sufficient airflow around the tube so that the upper airway can accommodate this airflow. As I've said, it's for patients with either deflated cuff or cuffless trach tubes. and for patients who have the upper airway patent. That means it is not obstructed by swelling, tumor, or vocal fold paralysis in the adducted position or some other anatomical anomaly that would impede the airflow through the upper airway. The indications for use, so the use of a speaking valve, the first time use, it's assessed by a speech-language pathologist. We assess for voice on finger occlusion and or leaked speech. The patient must have adequate secretion management, generally medically stable with stable vital signs as indicated below. And then if the patient is a candidate, we will write up our recommendations for the duration of the use of the speaking valve, whether the patient would be supervised directly or indirectly. Direct supervision means the patient is never alone with the valve on. The reason for that is that these patients may not have enough dexterity to remove the valve if they run into trouble, and or the cognitive ability that would allow them to recognize that they need to call for help or do something. So these patients we will usually use with direct supervision only. These are usually patients that are cognitively impaired, maybe in the ICU. At the Montreal General Hospital, it's mostly traumatic brain injury patients. On the other hand, patients who are under the OMF service or head and neck cancer patients who are cognitively intact can often manipulate speaking valves by themselves, and as such are allowed to use speaking valves with indirect or with no supervision at all. When we would recommend to remove a speaking valve, if the patient has a breathing difficulty, either their SpO2 decreases or their heart rate is increasing, or they even subjectively complain, I'm short of breath. If they are unable to clear their secretions, you might have to remove the valve and they will clear the secretions through the tracheostomy tube. If suddenly they are not able to produce voice, and I indicate suddenly because some patients we will use the speaking valve even though they are not speaking, but we will use it for pulmonary toileting and for the other benefits of the valve, which are respiratory, rather than just for speaking. And then we always recommend that the speaking valve is removed when a patient is sleeping. Cleaning of the speaking valve, because the membrane in the speaking valve is very fragile and sensitive, we do not recommend using any peroxide or alcohol, and the valve is cleaned only with warm soapy water, rinsed and then left to air dry and can be used immediately after. The speaking valve is one per patient only. It cannot be reprocessed to be used for other patients. So once the patient no longer needs the speaking valve, usually only after the patient is decannulated, the speaking valve is unfortunately discarded. What are the benefits of using a speaking valve? So yes, it restores speech naturally without the need for finger occlusion, but it also helps with secretion management. Patients have stronger cough because of the pressure that they are able to generate as a result of using the speaking valve. Because air is circulating through the upper airway, oral and nasal secretions are evaporated, so the speaking valve contributes to diminishing of secretions. That was the point I made a little bit earlier about using the speaking valve on patients who are not necessarily speaking, but we are using them for pulmonary and respiratory benefits. And there is research supporting the fact that a speaking valve facilitates weaning and expedites decannulation process. Passimure speaking valve has many studies that confirm or support the notion that patients are safer when swallowing. So tracheostomized patients should wear a valve while they are swallowing, and it can help in the decannulation process. We can also use a speaking valve in line with the ventilator, only if the patient is tolerating cough deflation. The speaking valve being used in line with ventilator is used with the assistance of our respiratory therapists because they have to adjust the ventilator settings. to compensate for the loss of the air that's now going to be leaking through the trachea because the cuff is deflated. But at DMUHC overall, our most common process is using speaking valves only once the patients are weaned from ventilators, unless they are long-term ventilated patients, and then we will use it on a ventilator as well. The Shiley speaking valve, the white one, was not designed to be used on the ventilator. We do not have any research supporting that they could be or could not be used, but they are not recommended for the ventilator use. And the valve that's actually one specifically designed was the green one that you saw a little bit earlier, the Passimure green speaking valve. So one message to remember is that speaking valves are not just for speech. Speaking valves should be used, and patients should wear the valves if they are able to tolerate it, even if they are able to speak without the valve. Many times we receive comments saying, oh, he doesn't need the valve because we can hear him even without the speaking valve. The benefit of the speaking valve, both to the patient but also to their patient's respiratory tract, is really huge in comparison to the fact that we can just hear the patient. So speaking valves are not just for speech, but also for respiratory and pulmonary and swallowing aid in weaning the patient off the tracheostomy tube. There is often a confusion between the speaking valve and a cork or a plug. The speaking valve, if placed at the end of a tracheostomy tube, allows inhalation through the trach tube. There is a membrane inside that opens with each exhalation, inhalation, and the air is coming through the tracheostomy tube that's placed here. Cork, when we plug the tracheostomy tube completely, there is no airflow through the tracheostomy tube, and the patient is breathing via their nose or mouth, just as you or I would. Corking trials are done prior to decannulation and are usually written as medical orders, so all you have to do is refer to the medical orders. If there is no air passing through the tracheostomy tube because the cork has been placed, by the same definition, there is no need for humidity that we usually provide through the trach collar. Thus, patients who are corked do not need the humidity and the trach collar and should not have it on while they are still in the hospital receiving treatment. What frequent questions do we receive about a speaking valve? I answered already the first one. Does the patient need a trach collar if the speaking valve is on? What if the patient doesn't need oxygen? So at the Montreal General Hospital, we provide oxygen and humidity through the same trach collar. So regardless of the fact whether a patient needs or does not need oxygen, they are getting some oxygen because that's the only way they can get humidity. But if they have a speaking valve on, remember, this is still opening. Thus, they do need humidity because they are breathing through here, not through the mouth, not through the nose, but through the tracheostomy tube. So the trach collar should be on. Whether the patient needs or does not need oxygen, it is there for humidity because normally we humidify the air that enters our lungs through our nose. Patients who breathe through the tracheostomy tubes cannot do so because they are breathing through here. There is no pathway to humidify it. Thus, we have to provide artificial humidity. Should the patient wear the speaking valve if eating? Again, as I stated earlier, it's not just a speaking valve. We should call it a swallowing valve as well. Yes, short answer, yes, they should. It helps restore pressures that are needed to pull the bolus and the food into the esophagus and stomach and aid in diminishing possible aspiration. Should a patient wear a speaking valve if sleeping? The answer is no, because our breathing pattern is different when we sleep. Patients may become disoriented or confused, try to remove the valve by themselves, and in the confusion, decannulate by mistake. Should the speaking valve be cleaned with peroxide? No. The membrane is very sensitive, and as stated earlier, it should just be lukewarm water with some soap, gently rinsed and left to air dry. What is the difference between speaking valve and cork? One allows for airflow through the tracheostomy tube, that's the speaking valve. The cork allows for airflow through the mouth and the nose, thus as if the tube was not in place. The patient has more oral secretions when wearing the valve. Why? Is that normal? Yes, it is. Now the patient is actually able to bring his or her secretions to their mouth. Thus, there will be more oral secretions, which they can either self-suction or eliminate in whichever way they see fit. Patient can talk even without a speaking valve. Does he still need to wear it? The answer is yes. Speaking valve is not just for speaking, as stated earlier. So in summary, communication is critical for inpatients. Many communication options are available for the tracheostomized patients. They are either non-speech options, writing, mouthing, communication boards or text-to-speech applications, or speech options, leaked speech, finger occlusion, speaking valves, talking tracheostomies, or an artificial larynx. Please do consult speech-language pathology if your patient has any difficulty communicating, and we will try to assist as much as we can in whichever way we can, evaluating which communication option would be the most optimal option for your patient. Thank you.